Well, welcome back to another special edition of Healthline 3. If you're watching us online, you're going to see a Healthline 3 box on the right-hand side of your screen. You can submit your questions there, or you can always give us a call at 318-219-4569 to talk live with the doctor. The best part about all of this, it is completely free of charge. Well, joining us today, we are talking with Dr. Charles Byrd of Willis-Knighton Health System about gallbladder surgery. And we are so excited to have you back on here. Good morning.
Good morning.
Or good afternoon now. My hours are mixed up.
That's right. Correct. I agree.
All right, Dr. Byrd, well, you do pretty much all types of surgery, but one that we want to focus on specifically today is gallbladder surgery.
Yes.
Let's talk a little bit about the procedure of laparoscopic surgery. Tell me the history of it.
Well, laparoscopic surgery really became an issue to alter the way we did normal surgery back in the 90s. Where we used to make big incisions in the abdomen to go out and remove gallbladders, take out appendix and things like that. And this became available, and Willis-Knighton was very kind to us to allow us to go away and learn this laparoscopic technique. And when it started, it began to change the recovery time of patients and gave them the ability to carry on their normal lives faster. For an example, appendectomies, when we made big incisions to go take the appendix out, they were in the hospital average of 3 to 4 days. Now laparoscopically can take the appendix out and then go in 1 day. Home and drive a car if they're adults in 2 days.
So it's completely different, changing not just the length of recovery time, but also I would imagine it sounds like because it's minimally invasive, you're not leaving so much scarring behind. What is the actual procedure like?
Well, the procedure basically, doing it in the abdomen, requires us to inflate the abdomen so we have room to look around. And there's a carbon dioxide thing we insert into the abdomen with a needle and blow up the abdominal wall so we can now see the intestines. And we put in these things called ports, little incisions, where we can put instruments through and actually we got a camera that goes through that so we can look at everything just as well as see it just as well as you could when you made a big old incision to come down and do it. So this is kind of what laparoscopic surgery does, but the minimally invasive surgery avoids having somebody experience the pain from making the big incision. And that's why the recovery is so good from this.
Is it still, they go under general anesthesia, is it still the same?
Yes, still a full general anesthetic. The point, I will talk in a minute, but a lot of the laparoscopic procedures we do, we let the patients go home the same day.
So an outpatient.
Right. I've done over 1,000 hernias, and the majority of them were done as an outpatient, and we discharged them to go home. The only reason why we would keep them in the hospital would be if they had a prior lung problem, for example, or a bad heart, so we want to observe them overnight, then let them go home the next day. As a matter of fact, I've done it on patients who were really chronically ill with bad hearts. They went home the next day doing fine.
So why would anybody want to opt to do the open surgery, the original procedure?
There aren't too many cases where an open procedure is necessary because you can basically do almost all of the abdominal surgeries now laparoscopically.
That is so interesting. So why the gallbladder? Why do we want to focus on that today?
Well, it's a point that a lot of people need to pay attention to because they're fearful. They're walking around with symptoms, said, oh, I don't want to go in the hospital and spend 3 to 5 days in the hospital getting well, which is no longer the case. The only people that stay in the hospital, I do majority of my gallbladders, I've done 3,000 or 4,000 of them laparoscopically. They go home the same day, 4 hours after surgery, and they can recover and drive a car in 3 days. The only thing they do in their diet is avoid fatty foods. That's what all people have to do after they've had their gallbladder removed.
Well, they say, oh, doctor, I don't want to avoid those fatty foods. I love them. I want to hold on to those. But now here we are. They're sick. Why is it important for someone to make sure that they do maintain a healthy gallbladder?
Well, a lot of things cause the gallbladder to form. And the thing we used to say all the time 30 and 40 years ago, that the most common people to have a gallbladder with gallstones are those who are women age 40 and who've had 2 babies. They were blaming it on that, but there are other reasons now. We see a lot of men with it who can't have babies. But basically, we're finding out that the cause of it is a diet-related issue.
Okay.
And you can form a gallstone.
Okay.
And I've got patients, I got a patient I'm going to do real soon who has a gallstone, a man, bigger than a golf ball.
So one of the things that I have learned is that gallbladder related, a lot of people will get the symptoms, but they don't realize that that's what the issue is, because the symptoms do mimic other diseases.
Yes.
How do you know when this is it? This is...
Well, the most common symptom we'll see with people who have a gallbladder issue. The most common thing is when they eat a meal, shortly after the meal they have discomfort in the upper abdomen on the right side. And if they're having a real gallbladder attack, they will have severe pain in the right side up near the rib cage, and that pain can radiate to the back and all the way to the right shoulder. And this is an acute attack. But a common symptom that we see with people with gallbladder issue is one who they can eat a meal, and right after the meal they feel like they got a lot of indigestion. Gallbladder attacks can mimic reflux.
Okay.
1 out of 10 patients entering the emergency room for severe chest pain mimicking a heart attack, 1 out of 10 actually are having gallbladder attacks.
That's crazy.
The gallbladder attack can mimic a heart attack. So you get heartburn and chest pain like that. These are all symptoms of it. So people with that, you don't need to go. I've operated on people recently who've had gallstones for years and years, and the gallbladder gets stopped up and starts turning to gangrene, ready to rupture. So that's why when we see them, we encourage them to go ahead, if they're having symptoms, please go ahead and get your gallbladder out now.
I want to talk a little bit about your background, and obviously you're a wealth of knowledge. You've been doing this for quite some time. You've been performing thousands of these laparoscopic procedures on the gallbladder. Tell me a little bit about your history, your background, and how you were one of the first in this area to actually do that.
Back in the mid-90s, there's another surgeon, and we were hearing about this laparoscopic approach. We never were trained, and there's no medical literature around for years before. And we started looking into it and found out how you can do it laparoscopically. So he and I went out of town to medical centers around the nation and watched how they were doing it. And we came back and we started doing laparoscopic gallbladders. The first ones in North Louisiana to do it.
Wow. And that was because you and your buddy, another surgeon, decided we're going to go and learn this.
We went dead to learn it, and once we learned it, we realized that this was an advantage, and started telling patients, oh my gosh, we can get your gallbladder out and you can go home the same day. And that we did.
And so now here we are. How many years have you been doing this?
Since 1995.
Look at that. So you definitely have a few years on your belt there, and you're very well versed in exactly how to do this properly, get your patients out safely, and then the incision that's left behind is minimal.
Minimal incisions, and the recovery time is fast, and it's good. And what we've done this on some people who, I'm going to say the phrase, morbidly obese, where a lot of people would try to go in and have to do it laparoscopically because of the thickness of the abdominal wall. We just can't do. Well, we've learned how to move into that and save them from having the open incision, because their complication rate following surgery is extremely high.
Right.
And
so we want them to be
as
not be
minimally invasive
under
as possible.
As much stress with the body. All right, speaking of that and someone being morbidly obese, let's talk a little bit about that diet and post-operation.
Okay.
What do you need to start doing?
The main thing, the gallbladder, all the gallbladder does, it stores bile that the liver makes. And the function of bile is when food enters into the intestines and it's released it's in the stomach and released to go into the intestines. If it has fat, a chemical is released by the intestines that stimulates the gallbladder to empty out its bile to help digest the fat that's present.
Okay.
If the fat is not digested that you eat, when it gets to the colon, it does the same thing to the colon that castor oil does. Castor oil is a fat the body can't digest. So diarrhea is a side effect. So what we do, and I watch most patients, 80% of the patient who have their gallbladder removed can usually eat their normal diet. 20% have to pay attention to the fat load. So if you go eat a lot, I tell them, if you eat 9 pieces of fried fish and have diarrhea, cut it back to 5 and see if you don't get away. Most people can adjust their diet and avoid this.
All right, but definitely we just try to stay off the fatty fried foods, but that's pretty tough to do here in the state of Louisiana where everything just tastes so good.
That's right. Now, of course, your heart's happy about it too.
Yeah, and your taste buds.
Yes, in a way.
Well, over time as they start to change, what is it that you see? Do you see patients coming back with any more issues of gallbladder, or do you see them finally say, hey, it's time for me to make a change?
There are problems related to doing any kind of surgery on the gallbladder, whether it's laparoscopic or open. Inflamed gallbladders will actually fuse to the liver. It's surrounded by a flap of tissue, thin tissue that holds the gallbladder there, but it's not part of the liver. But when the inflammation is, the gallbladder and the liver fuse together. When you take the gallbladder out, you have to separate it from the liver, and little tiny little channels that come draining bile to the main bile ducts can be opened up with that. You don't see it. It's microscopically small. You can leak bile out, and that could cause a fluid develop in the old bile pocket. And we treat that when we see that occur. We treat that having a radiology can put a little drain in for us and control that, and they all get better. So that's what the side effects we see from gallbladders that are really complicated. Usually uncomplicated ones, nothing like this happens.
So help me understand, the gallbladder, is that the actual name of the piece in the body, right? Yeah. It's called the gallbladder.
Yes.
The gallstones are what results
inside the gallbladder.
Okay.
And it's when a stone forms in the gallbladder and the gallbladder is told to empty out, that stone can be forced down to the neck of the gallbladder and stop
clogging
it up.
Okay.
And it hurts.
I see what happens there. So this is what creates the symptoms that tend to mimic other types of diseases, which leads people to being a little bit confused about what is actually going on in my body.
Absolutely, yes. Some gallbladders, with that stone caught in there, if they just says, oh, I want to wait, I don't want to have it fixed, that gallbladder, if it's totally obstructed for several days, it can slow down the circulation of blood to it, and it can turn to gangrene and rupture.
It's hard for me to think of gangrene happening inside of the body in that way. I always think of it as happening, to an exposed wound, but now this is something where I guess
if it's gangrene, it'll break through and rupture.
Wow.
And we have to do occasional ruptured gallbladder, but they're all treatable. We can do that laparoscopically and get it recovered and get everything washed out and everything.
So if it does rupture within the body, this is obviously spewing out toxins all throughout the body. So this is pretty scary. Could someone die as a result?
Well, they could die on a ruptured gallbladder if it's not treated.
Okay.
I've seen patients with a ruptured gallbladder that have been months after the rupture were still alive, but they were ill, really sick. So
get it done. That's the bottom line. Get in there and get it done. What do you recommend for somebody who's at home right now watching, who may be seeing those signs or symptoms of what could potentially be a...
The thing you would need to do, I would pay attention to, is you need to be evaluated, you need to have an ultrasound of the gallbladder, and you need to have some blood tests to see if the liver tests are abnormal. If the gallbladder is inflamed, the liver gets inflamed, and some certain normal blood tests rise in the liver. And also, if you pass a stone, if it's small enough, and I've seen a lot of that lately, that stone goes to the end of the bile duct and can stop it up. It may not get into the intestines, and the bile backs up in the blood, and you start getting yellow.
Oh, wow.
It's called jaundice. So these are all things we watch for whenever we see people. So We look at them, find out if they got suspicious symptoms of gallbladder. Then we do an ultrasound of the gallbladder to rule out a stone. Sometimes you can do a CAT scan if you're in the emergency room to see if there's something else. Anyway, do that, and after you do the ultrasound of the gallbladder, if you're questioned about really are there symptoms from the gallbladder or from something else, there's this test called a HIDA scan, hepatobiliary scan. They put dye in the blood, and it goes to the liver, and the liver releases it and fills up the gallbladder.
So and then it brightens it up.
They can recognize it because it's got a radiographic chemical in it. They got a special type of machine to look at. And they can stimulate, they give you this CCK stuff, stimulate the gallbladder to empty. And the gallbladder, normal gallbladder should empty out between 50% or more of its contents in 30 minutes. If it's less than 35, up 35 to 50%, it is borderline, but it's still abnormal. But less than 35% means that there is almost high-grade partial obstruction, and there's a danger, and you tell the patient, you don't need to go out of town. And I had a preacher that wanted to go to China, and I said, I can't let you go until I get your gallbladder out because you're going to wind up in the hospital there.
Oh my goodness. For somebody who maybe is trying to lose weight and they're starting to get these gallstones, and they think, oh no, I'll just try to let this pass naturally. Can this even disrupt their ability to try and let out, obviously, to flush out everything in their system?
This won't have helped us. Weight loss is great, but it won't change the gallbladder. It won't make things disappear. You still got the symptoms, and you still got the potential danger.
Okay, so this is definitely something that needs to be seen by a physician, by a surgeon.
Yes.
And let's talk a little bit about, again, the history of this, how long you've been doing these types of surgeries.
Well, when we first started doing the gallbladder, we realized that you can do some other things. We looked in there and said, golly, I could see things I was doing when I made a big open incision. And then I realized that somebody talked about, oh, yeah, you can do an appendectomy. So I watched some demonstrations from surgeons that were doing it and started doing it. Say, hey, it works fine. And then as time goes on, we realized that, oh, what about the stomach? Then I learned you could do a gastrectomy. I've taken the stomach out and reconnected intestines back up to the remaining stomach laparoscopically. All that's been something workable. Doing colon resection. That is something that really turned out to be a real great thing. We've done tons of them. And whenever people get the point of like diverticulitis, and you have to wind up doing a major abdominal surgery and then fix it up and do a colostomy on them and stuff like that, you can go in laparoscopically and do 80% of that laparoscopically and still do a colostomy. And the pain and recovery is still faster.
Wow.
And the recovery is just as good as you would do an open. So you got less problem with pain and stuff like that.
So for people who are still trying to understand what is this laparoscopic surgery, there is a camera that goes inside of there. Is that correct, to help you see better?
That's what we look at. That's what we look at, the camera. It magnifies things.
Okay.
It's a video, just like you're seeing my face. You can see the intestines exactly the same way.
That's so crazy to me. Dr. Byrd, we have our first caller. It is Paige who is calling in. And Paige, what is your question for Dr. Byrd today?
Yes, ma'am. I want to know, I had my gallbladder removed March the 4th of this year.
Okay. I'm going to repeat your question.
And I'm wondering, why do I still have diarrhea?
So she had her gallbladder removed on March 4th this year, and yet she's still experiencing symptoms of diarrhea. Is that accurate? Is that what you said, Paige?
Yes, whether I eat or not. Yes.
So she had it back in March, but she's still experiencing those symptoms.
Controlling the oral intake of your food is one step. And there are some, you can go to your primary care. There are some medicines, drugs on pills that you can take that'll help stimulate digestion of the fat you eat and reduce the diarrhea. And this is something that is easy to manage.
Okay.
I've never seen somebody stay with it forever, diarrhea.
Okay.
We've always been able to manage it, but eating a lot of fat, I would say some restaurants that really like to have great food everybody likes, but it's really a lot of grease, they're the ones that'll stimulate you. So you can overcome it by cutting back on the fat and then going forth and going to your primary care for what kind of capsule can I take before meal to inhibit us from having the diarrhea go undigested. I mean the fat going undigested.
And Paige, is there something in your diet that you think that you haven't fixed or changed that might be causing that, or are you saying that you have been eating healthier and you're still experiencing these kinds of symptoms?
Well, the thing is, whether I don't eat or do eat, if I don't eat, if I eat, as soon as I eat, I gotta go.
So she's even saying that even if she doesn't eat, she'll still have the diarrhea.
If the diarrhea occurs 30 minutes to an hour after eating a meal, we can blame some of that on it, but some other causes of diarrhea can do it. So primary care gastroenterologist needs to see her, and they'll be able to determine, because she could have comorbidities with multiple things. Gallbladder, she could have an irritable bowel syndrome in her colon, and all these things can help produce diarrhea.
Okay, did you hear that, Paige?
Yes, ma'am.
Do you have any other questions this afternoon? Did that answer everything for you?
Yeah, he answered everything for me. Thank you, doctor.
Excellent. Thank you so much, Paige, for calling in, and she appreciates you helping her out today, Dr. Byrd.
Okay.
And where can folks find you if they need to find a good surgeon?
I'm at Willis-Knighton. My primary office is at Willis-Knighton North, but I operate at Willis-Knighton North, Willis-Knighton South, and Willis-Knighton Piermont, all three.
Okay.
And I operate every day at one of them, or all of them sometimes. and my goal is to try to get patients treated, and a lot of patients are sent to me for potential surgery, and a large majority of them, I'm finding out, there are things that can be managed without surgical intervention. So there are things that I work on to, for
keep you from having to do that surgery. That's a good doctor.
Well, for a good example, and I'll give you this best example, people probably don't realize is having bowel movements. Majority of people are a constipated group, and that's what leads to the formation of diverticulosis. And diverticulosis is the thing that starts producing diverticulitis and complications for existing. And if you're on a high fiber diet, for example, you can soften up the bowel movement and the colon starts emptying out without stress, and it reduces this problem. So these are things you can monitor and avoid. And I tell patients, if you do this and we can stop seeing you in the office, you're going to stay better.
All right, high fiber foods just sound like it's the way to go, period.
Yeah.
I was so impressed. You even told me that you had performed a surgery this morning.
Yeah.
So that's real in and out patient quite quickly.
Yes.
It was what, a few minutes, you say, or a couple hours?
Well, it was a 30-minute procedure.
Look at that, pretty quick, pretty easy.
Yes.
You have definitely mastered the skill.
Well, the laparoscopic gallbladder surgery has gotten to be so easy to get done. In the old way of doing the open incisions that some people are still doing, would take us 45 minutes to an hour and a half to get done.
Wow.
And my fastest gallbladder that I've done was 13 minutes. So if you can get in and get something done and get it out quick, that way, and they go home feeling better, it's good.
13 minutes? Is that a world record?
For me, it's a world record. I don't know about
fast.
Somebody else.
I love that. Let's talk a little bit again about the diet, because I think that's so important, because it impacts so many other parts of the body. When you do get those patients who you say you can try to treat them without doing the surgery, what is it that you do tell them to do?
Well, there's some fiber products that people think they're eating to get fiber in, and
products, so not whole foods. We're talking about maybe an enhancement or something.
Well, actually, cereal, for example.
Okay.
A lot of cereals are high fiber, all brand buds and stuff like that. You need to get a minimum of 25 grams of fiber a day
in your diet,
and that allows for your colon to perform reducing the tension to pushing things through. I know it sounds ugly, and I don't want to be ugly about it, but a lot of people who don't have bowel movements often, the stool becomes firm and like a little ball, and it's hard for the colon to move it through, and that's what makes it pooch out the diverticulum. So we work on a way of trying to restore that, and I found a large number of people coming in to me for that. I says, if we can, I use this phrase, toilet train you, we'll get you delivered from this. And a majority of them have avoided requiring surgery.
Look at that. I
Yeah.
love it. I'm over here laughing like a little kid because I just pictured it in my head. But it's so important that you teach people this because we don't learn.
No.
I didn't learn growing up that you needed 25 grams of fiber until I got older and started learning a lot more about food.
Yes.
And it's so hard to even get that nowadays.
Well, I have a list in my office when I see patients with things they can put on their diet and form. And they talked about one cereal. There's a cereal called All Brand Buds. It's a new one. And 1/3 cup gives you
Just 2 grams of
11
fiber.
grams
Oh,
of fiber.
what brand is this?
All Brand Buds. And if you eat a whole cup of that, you get 33 grams of fiber. And guess what?
That's it.
You're at good level. And I've had patients, once they start doing this, they come back and say, oh, you don't know what has happened. And it's so much better and easier. I said, yes.
Dr. Byrd, you just made my day because I tell you, when you're regular, the world feels right.
Right.
Everything moves nice and smooth.
Right.
Any other way, not so good.
You're right.
Otherwise, we're going to have to go and see the physician, and that is not a good thing. We want to try and stay out of the surgical table.
I tell patients, stay out of my office, you stay out of trouble.
I love it. You're such a sweetheart. Like, how is it that you are a surgeon, and yet you're still like a comedian? You like to have fun.
Well,
I love it.
But I know, I believe in, don't get mad at me, supernatural help.
That's
working
a good
through
thing.
everything, and
You
peace.
pray through it.
I do on every patient.
That's nothing to be ashamed of. I talk
And
about it all the time.
Peace comes with people who walk that way.
Amen. I love that. And I like the fact that you really want to help your patients. Like you said, stay out of your office. You want to help them before they get to that point, once they're in that point, and even if they have avoided seeing the surgeon and something has erupted inside of their body, you can still try and take care of that.
That's true.
Is there anything that we're missing out that I haven't asked you?
I can't think of anything. You've asked lots of good questions, and I like them. Yes.
Good. Well, I like it. I'm learning from you. So all brand, we've learned high in fiber, get those 25 grams in a day. Try to get a nice, good bowel movement going. For those people who are experiencing diarrhea, like the caller that we just had, what is happening in her body that is still occurring, if it's related to the gallbladder
It
surgery?
could be. Once you get the gallbladder out, something's causing the diarrhea, and you got to see, is it food, chemicals in the food, or underlying disease in the colon producing it? And that's why you get the workup by the gastroenterologist, and you can have a good recovery.
So it could also be, like you were saying, the foods that she's still eating at this point, or that somebody would be eating even after surgery.
That's right.
So try to stay away from those fatty foods, continue to eat good fiber, and just have a well-rounded diet.
Well, I have seen people with the diarrhea start doing the fiber, and guess what?
It all changes.
It firms it up and makes it less watery.
Look at that. So big changes can happen with just those simple changes that you make at home without having to go and get surgery again or having to see a physician.
Right.
So we have 1 minute left in the show. Once again, I know you mentioned it earlier, but where are you located at, and where do you perform your surgeries for Willis-Knighton?
Well, Willis-Knighton North, Willis-Knighton South, and Willis-Knighton Piermont. They come to my office at Willis-Knighton North. They can make an appointment. We'll come in and decide if they've got an issue that requires surgical intervention, and then we'll let them choose which hospital they want to go to.
All right, something that's much closer to them and something that works with them. And real quick, are you from Shreveport, Bossier?
Well, I'm from a place called Leesville,
Okay.
south of here, but I came to Shreveport and went to Centenary College, then went to medical school at Tulane, then came back up here, to what's now called LSU, and did my surgery residency.
And you decided to stay.
I stayed. Well, I had to go in the Air Force for 2 years because we were drafted at that time for Vietnam.
Don't you just hate these youngsters now? They don't have to get drafted?
They don't know.
They just don't know.
No.
I want to thank you so much, Dr. Byrd.
Okay.
You have been a blessing to chat with today, and I know that our viewers have also felt the same. So thank you so much for coming on.
Thank you. Okay.
All right, everybody, have a blessed and wonderful day. We'll see you later.